there we go. Okay, great. Okay, so welcome to tonight's webinar, which is part of our Personal Perspectives series. And in this series, we feature members of our Marfan, Loeys-Dietz, and VEDS community and give you insights that we hope will help you improve your quality of life. Tonight, we're focusing on physical activity and exercise. And I think the goal really tonight is to give you a lot of information and personal experiences to help you make the best decision for yourself, your family, in conjunction with your doctors. Before I introduce the panelists quickly, I would want to thank those of you who pre-submitted questions. If you have additional questions, please feel free to type them in the Q&A box. We're going to answer as many as we can tonight, but again, I ask that maybe you wait until after the medical presentation part because your questions might be answered. If you have additional questions afterward, or if your question is not answered, you can submit it to our Help and Resource Center. And Helene's going to put that link in the chat box, and I'll also put it up on the screen later. It'll be in the follow-up email, so you'll have a chance to ask your questions to get them answered. So just to briefly introduce our panelists, because they're going to all be talking about themselves as well. Our medical experts tonight are Dr. Alan Braverman, who is the Alumni Endowed Professor in Cardiovascular Diseases and the director of the Marfan Syndrome and Aortopathy Clinic at Barnes-Jewish Hospital in St. Louis, and Dr. Mary Sheppard, who's the Assistant Professor of Family and Community Medicine at University of Kentucky. Dr. Braverman is also on our Professional Advisory Board and our Board of Directors. And both have a very special interest and done research on connective tissue conditions and exercise and physical activity. Our community members who are speaking tonight, I'm not going to tell you much about them, but as you see their faces on the PowerPoint and on the screen, kind of double duty here, Alan Tucker, Morgan Jozwiak, and Samantha Stallings. And they will tell you their stories as they relate to physical activity and their connective tissue conditions tonight. So first, we're going to start with Dr. Braverman and Dr. Sheppard. So the rest of us will turn our cameras off, and I'll let them take over.
Okay, welcome, and it's a privilege to be here with everybody today. As Eileen said, Mary and I are going to tag team and really just give some basic information and kind of a broad overview on what to think about when approaching exercise and physical activity for people who have a heritable thoracic aortic condition. And really to emphasize that many of the things we'll talk about are very broad strokes, and we do have to individualize it because everybody's condition's a little bit different. So, let me start. This is a very important slide emphasizing how important it is for all of us, every one of us on this call, including myself, to get enough steps in and to be active and for our health and well-being. And we want to emphasize with the next slide how important exercise is, whether it be with regard to the heart and blood vessels, the skeletal system in your bones, your blood sugar, the social aspects, how good it is for our waistline, how it lowers risk of certain types of cancers, and how important it is from a mental health standpoint. So health and well-being are very importantly impacted by routine exercise. And next slide. So what do we know about exercise? How much is safe? It really depends. What's the condition? What's the condition of the aorta? What's the age of the individual? What type of sport is being performed? What intensity and things like that. In general, you know you're doing too much exercise or physical activity if you can't breathe or you can't talk or you're straining yourself tremendously during that activity to be able to continue it. So in general, things that are done at a recreational pace in a conversational voice are certainly safe. And many things can be done at above that level. But when you start to strain or grunt or can't do more, then you're really reaching a threshold. And the type of physical activities people ask about what I shouldn't do, that's a hard one to say what you shouldn't do. Really, we try to emphasize all the things that you should do. But in general, intense weight training at highest levels where you're really straining your muscles have had fatigue and you can't do anything more, that's usually past the threshold because then it affects blood pressure and aortic wall stress. Next slide. what if you choose to do high-risk physical activities? Well, what we'll talk about today is what we know about those sort of things, consequences. And the good news is most people who do most types of physical activity who have a heritable connective tissue or thoracic condition are generally going to be safe. So we're going to emphasize all the things that we consider to be low risk and then talk about some of the other things. Next slide. Okay, people ask about a heart rate during exercise. That's really kind of tricky because everybody's heart rate starts at a different level, especially if you're on medication. You might have a resting heart rate of 40 or 50 or things like that. And so a target heart rate really may not be as important. Really what we think, and some people start with a heart rate of 90 or 100. So to them, a heart rate going 110 won't be much activity at all. So really less than heart rate, we think about how the activity level is perceived, how much effort's being undertaken. And we certainly don't always have the right answer about that. Importantly, all the things that Dr. Sheppard and I are going to talk about today are really based on our best estimates on what sort of things make sense, a common sense approach, a consensus, and really expert opinion. There are no outcomes data where we've done studies looking at different types of exercise saying, we know that this is going to be harmful and this is not going to be harmful, or this is safe and this is not safe in people who have connective tissue conditions like Marfan and others. It's really based on consensus. Next slide. In some people, it's not just the blood pressure response or the aorta that we think about, but of course, risks to other parts of the body that can be involved. Like in Marfan syndrome, someone could have a dislocated lens or be at risk for retinal detachment. So head trauma or strikes to the head or sudden impact or collision can play an important role. And the same thing goes in the skeletal system. It might be more impactful in Loeys-Dietz syndrome, where the cervical spine can have a problem, or someone could have a problem with a foot or a hip that could be impacted with certain types of exercise, but not others. So you can see we really do have to kind of individualize the recommendations based on the underlying condition. Next slide. And then the aorta is different in everyone. On the slide to your left, next slide, we'll have an arrow pointing to the aorta in someone that looks normal. So that's a normal size aorta in someone with Marfan syndrome. And the next slide shows a dilated aorta in someone with Marfan syndrome. So this physical activity or exercise guidelines might be a little bit different for someone whose aorta is approaching a surgical threshold as opposed to someone whose aorta looks very normal. And the next slide shows somebody who's had an aortic dissection and then underwent surgery after this, but still has residual dissection in the descending aorta. So it's still important for this individual to exercise and be active, but the levels of activity may be different for this person than someone whose aorta looks normal. Next slide. Okay, I'll stop here and Dr. Sheppard will begin the next portion of the discussion. You may have to unmute, Mary.
Okay, great. Thank you. Although we often talk about exercise as a general category, it's really important to emphasize that not all types of exercise are the same. Certain activities lead to more demands on the cardiovascular system, such as static or isometric exercise. In isometric exercise, the length of muscle fibers do not change during contraction, resulting in sustained compression of peripheral blood vessels. Even though blood pressure increases during both dynamic and static exercise causes a higher rise in blood pressure because it does not cause dilation of those peripheral blood vessels. In addition to static versus dynamic considerations, exercise intensity impacts the blood pressure and heart rate response to exercise. Therefore, a distinction is often made between competitive and recreational athletics. Of course, it is absolutely possible for a low-intensity sport to be highly competitive. A great example of that is professional golf. However, it is common for athletes to push their exertion to a higher level of intensity when competing compared to when they play a sport recreationally. Blood pressure and heart rate response to exercise can depend then on the type of activity, the level of intensity, and the conditioning of the individual. One way to kind of equalize for some of these different variables is something called the metabolic equivalent of task, which is a physiologic measure expressing the energy cost or calories of physical activities. While exercising, the MET equivalent is the energy expended compared to rest. So MET values indicate intensity. This chart lists the number of METs required to perform different types of activities. And it can be a helpful gauge when you're considering the intensity of your activities that you perform recreationally. In general, systolic blood pressure may increase by 8 to 12 millimeters of mercury per MET of aerobic activity. Since blood pressure directly impacts aortic wall stress, it is recommended to avoid high increases in blood pressure. This can require limiting activities performed with maximum intensity. Of course, conditioning and medications can also mitigate increases in blood pressure. Since static and dynamic activities impact blood pressure differently, the 2015 American Heart Association, American College of Cardiology guidelines reclassified sports according to the intensity of both their static and dynamic components. In this graph, you can see that activities are ranked according to their increasing static component along the y-axis as you move from the white to the red boxes. Activities are ranked according to the increasing dynamic component across the x-axis as you move from white to blue. According to this classification, the highest risk activities, especially for a person with a heritable thoracic aortic condition, are those listed in the boxes that are red and purple. In addition to intensity considerations, activities with a high likelihood of physical impact need to be avoided. Activities are grouped according to impact risk at the junior high school level, as well as the high school college level here in this chart.
Thank you, Mary. I'm going to speak a little bit about a concern that many people have is if I exercise, will that cause harm to my aorta? What do we know about that? So we'll, next slide. Or does exercise make my aorta become larger, or can it cause an aortic dissection? Next slide. On the very end of the spectrum would be someone who is an intense bodybuilder or weight trainer, strength-trained individuals that are lifting their maximum amount of weight, doing what's called the Valsalva maneuver. You have to bear down and grunt and push as hard as you possibly can to lift a weight. And in that setting, when you lift your maximum and strain as hard as you possibly can, the blood pressure can rise dramatically, even over 300 millimeters of mercury, where normal blood pressure might be 100 or 120. And that sort of surge in blood pressure would be the concern to the aorta when it's weaker than normal or enlarged. And that's the sort of thing that people might worry about, but thankfully, that is a very rare phenomenon. There are reports of it in the literature, but that's an uncommon phenomenon. But we do recommend this would be one type of activity that we'd say, really stay away from intense physical activity with intense weight training. Now, that does not mean that it's unsafe to do normal daily life, carrying in the groceries, picking up your child, pushing a lawnmower that doesn't require any significant effort, bringing a gallon of milk in, etc. All those things that are part of normal life are perfectly low risk. Even weight training in low levels where you're just building tone, but not reaching muscle fatigue, doing light isometrics, but not straining yourself are considered to be low risk for the vast majority of people. Next slide. What about if I exercise over time? Does it have any impact on my aorta? Next slide. In athletes, again, elite athletes, these are Olympians, national champions, things like that. The aorta is a little bit bigger in people that are elite athletes, especially in strength-trained athletes compared to those that aren't athletic. Next slide. This is just documentation of that in a study of weight trainers from Iran. Next slide. Next slide. In the green bar are the athletes that exercise the longest period of time with the most intense weight training over months and months as opposed to a short time. And it does show there's a little bit increased aortic size in long-term strength-trained athletes. And so we think about that when we think about someone with an underlying aortic condition and that type of exercise being potentially at risk. But again, there really are no data looking at that to see, is this a protective effect to the aorta? Is this a remodeling effect? Or is this a harmful effect? And there's studies of endurance athletes that have done marathons and endurance cycling for 10 years, starting at age 50 years old and older, and they do have larger aortas than regular people who don't do that type of exercise, but we don't see harmful effects. So there was a lot to learn about the aorta in athletes that might have an impact on how we advise the people we care for who have conditions where the aorta is at risk. Next slide. Thankfully, dying suddenly when you're an athlete is very, very rare. So it's a rare phenomenon in general. And of that rare complication, only 2% of death in athletes during competition are related to aortic complications. So 2% of a very rare phenomenon. Next slide. Next slide. Similarly, over 2,600 deaths in athletes, only 1% of these rare phenomenon were related to aortic dissection. Next slide. And most did have suspect Marfan or a related condition. And the sports were the most commonly performed sports, of course. Football, baseball, and basketball were most associated in this rare phenomenon. So this is what we think about, although this is only the tip of the iceberg. What we do understand is that most physical activity performed at a recreational level is considered to be low risk. So that's what we really want to emphasize. Next slide. This talks about the weightlifting and the very small series of dissections associated with weight training. On the counter, if we look at the largest data sets of aortic dissection and ask, what were you doing when an aortic dissection occurred? Only a very small minority are related to intense physical activity. Most occur during normal daily life. So we don't really know what triggers aortic dissection for the majority of individuals. Next slide. Do we know about exercise or intense exercise in people with Marfan syndrome? We really don't, because once somebody is recognized as having Marfan syndrome, it's generally recommended that instead of doing the most intense competitive exercise, that things are done at a different level. So we don't really have good information about what might happen if somebody who's known to have Marfan syndrome were to continue doing exercise at the most intense level. Next slide. Mary, I think this will go to you.
Thank you. So looking at the best data that we have available, what do the guidelines recommend regarding competitive sports and people with Marfan syndrome and related disorders? The American College of Cardiology and the American Heart Association said that it's reasonable for athletes with Marfan syndrome to participate in low and moderate, static and low dynamic competitive sports if they do not have significant aortic root dilation, moderate to severe mitral regurgitation, left ventricular systolic dysfunction, and a family history of an aortic dissection at a diameter less than 5 centimeters. It's really important to emphasize this is a very, very conservative guideline, and that this is based on expert consensus. We're starting to get more data, and to consider that in the absence of data, that medical professionals will always err on the side of safety. They've also said that it's reasonable for athletes with Loeys-Dietz syndrome, FTAA syndrome, or VEDS to participate in the same low static, low dynamic sports if they do not have aortic enlargement or dissection, branch vessel enlargement, moderate to severe mitral regurg, and extracardiac organ system involvement that would make participation hazardous. So those are kind of those multisystemic manifestations. And for athletes with Marfan syndrome, FTAA, Loeys-Dietz syndrome, unexplained aortic aneurysm, VEDS, or a related aortic aneurysm disorder, they should not compete in any competitive sports that involve intense physical exertion or the potential for bodily collision. So basically that's saying high intensity activities, high contact activities really need to be avoided. It's important to emphasize also that medications can have a significant impact on physical activity, and a lot of times in different ways. So for example, beta blockers have the greatest impact on decreasing heart rate during an exercise or regular activity. Losartan does not affect heart rate, but it does significantly decrease blood pressure. And another important consideration is that, if you are on a blood thinner, such as warfarin, the risk of bleeding is increased. So it is especially critical to avoid contact sports or activities with a high fall risk. I was alluding to some recent research that has been published. This is from 2017 by Gepson's team. Recent mouse studies have suggested that mild to moderate dynamic exercise may actually decrease aortic dilation in a mouse model of Marfan syndrome. The mice in this study were exercised on a treadmill for 5 months, and importantly, starting at 4 weeks of age. So this would be pre-puberty for a mouse. Elastin fiber length, elastin fragmentation, and wall elasticity was most improved at a 55% maximum dynamic activity level. But the benefit progressively declined as exercise intensity increased above 55%. Exercise provides many important benefits. In a survey of 314 survivors of aortic dissection, those who exercise regularly experienced lower blood pressure and had less depression. And it's important to note that these numbers of depression are real and significant. 32% reported new onset depression after an aortic dissection event, 32% with new onset anxiety, and 24% were too afraid to engage in any exercise at all after it. And cardiac rehab has also been found to be very successful in selected individuals. This has to be individualized, and we recognize that as of today, a lot of communities don't have this resource available, or insurance is not providing reimbursement, which are more things we need to get more data to help support. So what about recreational exercise? We talked about the guidelines for competitive. Mainly, and what we have here is listed ACC/AHA guidelines, Marfan Foundation, Loeys-Dietz Foundation. But in summary, avoid contact activities with a high static component, but continue to perform dynamic activities at a light to moderate intensity. And then this chart lists specific activities according to these considerations. For the categories in orange, participation really needs to be individualized based on shared decision-making with your physician. The green are generally very safe and reasonable. And in red, we feel like these are very high risk based on contact, high static components, and the necessity for a high dynamic component to perform that activity. A quick way, and I love this as a trick, to gauge how intense the dynamic component of your activity is. It depends on whether or not you can carry on a conversation while being active. So as you can see here with the 2 to 3, light activity. Feels like you can maintain this activity for hours, is easy to breathe and carry on a conversation. So if you're jogging, if you're walking, if you are playing doubles tennis, and you can still carry on a conversation at the same time, keep going. And the overall thing that we wanted to emphasize today is that the right type of exercise is safe and critically important for the well-being of people with heritable thoracic aortic conditions. We want to help to eliminate fears so that everybody can enjoy life to the greatest degree possible.
Great, thank you so much, but I think you have to hit, oh, okay, there you go. So thank you so much for all that great information. I know that you addressed a lot of what people were asking ahead of time. And so now what I'd like to do is invite our other panelists back, Alan, Morgan, and Samantha. And I'd like to do is have you each talk a little bit about, just take a couple of minutes, tell us who you are, where you are, and about your physical activity and what your connection is to Marfan, Loeys-Dietz, and VEDS. And I think what we're going to do, saw a lot of talk about football in there. So we're going to start with Alan, and looking forward to hearing from you. You and I have talked about this for so long. Here we are.
Yeah. All right. Can everybody hear me?
Yes, you're good.
Cool. I haven't been on the Zoom in a little while. Yeah. So I'm going to have a unique perspective for sure, because everything they were saying not to do on that presentation, I was doing. Thankfully, I got diagnosed and everything's fine now. But my name's Alan Tucker. I'm currently in Mississippi. I'm 28. I was diagnosed when I was 18. At the time, I was playing college football at Mississippi State University, which is in the SEC, so pretty high level. And I also had open heart surgery when I was 26, so 2 years ago. So I kind of have both perspectives of a guy that was told, hey, you gotta chill out because you got Marfan syndrome and a connective tissue disorder. And then again told, hey, you got to get your body ready because you're about to have open heart syndrome. And then, hey, you got to kind of adjust how you work out post-surgery. So I got a little bit of perspective on this exercise with heart disease thing. But yeah, I hope I can answer people's questions. I've done just about everything as far as physical activity. So feel free to ask me, what strain it puts on the body. But that was a great job by Dr. Braverman and Dr. Sheppard right there. Just talking about, what's most important is that you do something. So mainly for the mental aspect of it, the worst thing you can do is nothing. So yeah, it's a great point they made, and I'll hand it off to the next panelist.
Great. Thanks so much. Definitely have some questions for you. I'm going to toss it over to Samantha now. So if you tell us a little bit about your story and what, and physical activity.
Samantha, you have to unmute.
There you go.
I'm Samantha Stallings. I have Loeys-Dietz syndrome type 3. I am 29 years old. When I was about 8 years old, I got sent to the cardiologist. Back then, Loeys-Dietz really wasn't around, but or researched, I should say. And so the talk of having something was out there, but it was never guaranteed, or it was never put into writing. So I kind of went on as a normal 8-year-old. I played softball, I played volleyball, I played 1 year basketball. But my main course of sport was swimming. When I was in 7th grade, I was diagnosed with Chiari malformation. So that put a hold on every single sport but swimming. And then I was diagnosed with Loeys-Dietz when I was about 24 years old. And with not being diagnosed till then, Chiari kind of stopped everything. So when I was diagnosed with Chiari, I also got sent for genetic testing see what I could have as far as connective tissue. And Loeys-Dietz still wasn't popping up. And then it popped up a couple years later. But swimming was always something that I always did. And back when I was a sophomore in high school, I was swimming for my high school swim team, and I was told by my neurosurgeon to no longer dive in the pool. And so that's where it ended.
Great, thank you so much for that. We have another perspective now, and this is Morgan's perspective as a parent of a son with VEDS. So go ahead, Morgan.
Hi, I'm Morgan Jozwiak. I'm in the Houston, Texas area. And like she just said, I have a 12-year-old with vascular EDS. I have a slight perspective from like physical activity. I run marathons and half marathons regularly. So I understand the strain on the body, but I also, my son, he was diagnosed 2 years ago, and at the time he was in tackle football that I had to pull him out of. And since then, a lot of changes have had to be made to physical activity. And he was diagnosed years after his dad passed away at the age of 21 from an aortic dissection that he was not genetically tested for any type of connective tissue disorder at the time. So we had to wait about 7 years to figure out that he had inherited it from his dad. And I'm here to give any perspectives on, you know, a child growing up knowing they have it, and how we make it work the best possible for him to be happy is the most important.
Yeah, so I just wanted to kind of start the discussion off with a little bit about like your attitude about exercise and figuring out what's right for you. Because I think what, you know, the doctors told us tonight, they give their best recommendations, and you know, people have to judge really. And I think a lot of it is based on, you know, the physical things they talked about tonight, but also, you know, the mental part of it. So maybe Alan, if you can start us off as being like, you know, a D1 athlete and having to change how you approach that. Obviously sports was a big part of your life, you know, your entire life. So what was the mental part of it, and having the acceptance, and what kind of changes did you make?
Yeah, like Dr. Braverman said, every person's different. That's the biggest thing. So, you know, what one person can handle, other people can't. The mental aspect of it, I was told basically to stop that same day that I was diagnosed. I apologize, I didn't give enough backstory. I have Marfan syndrome. I don't think I said that, but my father passed away when I was 1. He had an aortic dissection. And so that sparked them to test me after a practice where I was short of breath and kind of fell out a little bit after practice. And so that's what caused me to go get checked. Thank goodness I did. But that day they told me to stop, you know, basically doing everything exercise wise with football, because it was, like they explained, very high intensity. You know, in the summers we trained with Navy SEALs. They would come do the whole, you roll with a log, you know, you're rolling through water. It was intense for sure. So I went from doing, you know, the highest intensity workouts possible to more cardio, you know, less intensity, which saved my life, honestly. So when they checked my aortic valve, it was very, very large. There was no making it smaller, so I just had to kind of tolerate it. What I had to do was basically just switch my mindset from the intense, hey, let's get this done. I got a rep, you know, I got a set of 8, and I got three sets, and I got to bang it out real quick, right? I'm running to the next exercise. Had to learn, you know, to take my time, do longer workouts, I would say, as opposed to the high intensity short workouts. And so obviously I've always ran. So that was something I could kind of go to mentally decompress. If I was ever, you know, feeling down about not being able to go out there and squat 400 pounds and bench press and, you know, could do all those things. So running definitely kind of got my mental state back to where it needed to be. But yeah, there was a major change in my workout plan, but yeah, there was not a lot of research out there on what someone with Marfan syndrome should do. There's no workout plans for people with heart conditions out there. Even today, I think I looked like couple weeks ago for one, still couldn't find one. So every person is going to be different. The best thing you can do is reach out to professionals. I have a best friend that's a trainer, and he gave me a pretty good workout plan. But you're right. Yeah, you gotta sit, sit and look in the mirror and say, look, we got to make a change, but it's for the better. It's in the long run. This is going to keep me alive. But I'm fired up because every day I get to find a new hit workout that I can do, or new run, or there's hot yoga. There's all this stuff out there nowadays that are good for me. And so the only thing different is just, rather than taking 30 seconds between a set, you just take a minute. That's what you got to do, and you know yourself better than anybody. So that was long-winded, but I hope that helped out.
But you're still involved with Mississippi State football, so you don't.
Yeah. So my job is kind of contradicting to my lifestyle, but I coach football, and so I'm telling these kids to do these big workouts, and a lot of times they'll laugh and tell me to get down there and do it when they know I can't. But yeah, it's all good because I can kind of stay connected to that intense lifestyle without it putting me in danger.
That's really great. Samantha, do you want to talk about the mental aspect a little bit?
Yeah, so when I had to make a lot of my changes, I was in 7th grade, and my mom probably could talk a little bit better because I don't remember much because it was so long ago. But in 7th grade, you're kind of still trying to find your friends, and you're getting ready to move to high school within 2 years. And I had to quit volleyball, and me being sick, I was 6'1", 6'2" at the time, and everyone's always asking, did you play basketball? Did you play volleyball? And even to this day, I'm 6'3", and people are always asking me what I played, and I always say swimming. Like, oh well, you must have been Michael Phelps. And it's just one of those things that people assume height, and they assume you have all this great ability, and you just there's always a good reason behind it when you don't. But for me, I always had swimming to fall back on. And even to this day, I teach swim lessons, and it's just one of those things that swimming has always been there for me. No matter if it's obviously not high intensity anymore, but it's something that I've always had and been able to do. And my doctors always had told me that swimming has saved my life.
That's great. That's good. Morgan, as a parent, I know a lot of parents want to protect their kids and also direct them, and then at the same time, they're athletes like you are, and they have hopes for their children, and you have to kind of rethink some of that, maybe. Can you talk about that a little bit?
Yeah, our background, we're an athletic family. Like I said, I run high intensity running. I compete in endurance running. My fiance is a weightlifter, bodybuilder. So, we got that background. And then when you're told, no, he can't, basically he can't do anything. And it's like, oh, okay. That's a big, shocker. So the first day that I pulled him out, he was very angry about it. And as a 10-year-old, I think he handled it the best that he could. Even to this day, it's been 2 years. He still has told me he doesn't really accept it fully. It still makes him angry that he can't do the things that he wants to do. He'll still come up with a plot of how he's going to convince the doctor that it'll be a good idea for him to play competitive basketball or, something like that, which doesn't happen. He does now watch a lot of football. He really enjoyed football. So that's kind of the only connection that he has to it. But at the time we started going to the games and, okay, well, we'll support the team because he left. And he really didn't like that. It made him jealous to see everybody else doing it, and he couldn't. It made him feel useless to sit on the side. So I was surprised that actually didn't work out to be a way to be involved. He just felt he wanted to be the one on the field and not on the side. So we had to stop going to those, but he likes to watch the professional, on TV. And then I think it was also a switch to back to what can you do? It's not all about what you can't do, it's what you can do. So he started doing golf. He got very involved in golf. He also started doing the more recreational type of, jogging, the recumbent bike at a gym, those types of exercises where you're moving and but you're not straining, so that he didn't feel completely left out, even at this young age. And I think another area that really helped him was physical therapy, because even with the jogging, like around a track, he was in pain. His joints were in pain. His knees were dislocating. His shoulders were dislocating, or I should say subluxation, not dislocation. I use it so interchangeably. But physical therapy, we did that twice a week for about a year, for hour to 2 hours at a time, and that worked wonders. It was night and day. He went from having 20 subluxations a day to none. He may have one a month now, just doing those light exercises that keep the muscles around the joints, healthy and working. And I think that gets back to the points that, Dr. Sheppard and Dr. Braverman made, that, doing those lighter exercises, it benefits everybody, and it benefits your body in other ways, that as long as you're not spiking the blood pressure and your doctor's, okay with it, it's important to do those things, to live a quality life. You don't want to be in pain all the time, and you want to be a part of it.
Great, thank you so much. We do have questions for each of you, but I want to kind of take this question to our two doctors. First, Alan, as an adult cardiologist, maybe you've seen people, for a long time, or maybe they're just diagnosed as adults and already have like an active lifestyle or are really into competitive sports. So how do you, how do you counsel patients besides all the data that you gave us earlier tonight? Like, what do you say to them? What's that conversation like?
Well, first, I loved hearing the stories that Morgan and Alan and Samantha said. They mirror everything that we hear every day. And my oldest brother, who has Marfan syndrome, was diagnosed, after he finished his competitive sports and athletics through high school, where he was a bodybuilder and weightlifter and all-state basketball player. And he used to throw the shot put. He would do what Alan would do, lifting 300 or 400 pounds. And thankfully, when he was diagnosed, his aorta hadn't dissected. It was 7 centimeters. I still shudder to think about that and how lucky he was. And for him, when he was told he had to stop kind of cold turkey, just like Alan was, it was devastating for him. He enjoyed that, the high of, competing at the highest level so much, just like Morgan's son does at 10 years old, because how would you not? It's just such a great endorphin rush. So I think it's really a challenge to take away something that you really love. So I think just hearing how healthy the choices that you guys made, and it's such great advice, but it takes time to get to that. And just like Morgan's son, it doesn't happen overnight. It just happens in leaps and bounds. But so in someone that's used to doing, the highest impact sort of things, I usually say, let's find things that you love. And I never put weight limits on things. I don't like to put times on things, because those are so arbitrary. I really say, if you want to run, let's run at just a different pace. You don't have to go as far or as fast, or you don't have to get up that hill. You don't have to be, when you're cycling with your friends, you don't have to be the leader of the pack. Now you can actually be where I am, more toward the middle or the end of the pack, and you still enjoy, you get to see the scenery. I try to, make it, real and practical, and emphasize how important it is. It's lifelong. I said, you're going to live a long time. So you got to take care of all those joints. And just like Morgan said about her son, you strengthen the muscles. And not everybody's as fortunate to have a physical therapist that's so in tune with those sort of things that make a difference. And that's a really important part of it. Some of the questions were about, what is an orthopedist the right person? It might be a chiropractor, an orthopedist, a physiatrist, a physical therapist that's really has an interest in this condition and in helping people maximize their success and minimize the joint problems, whether it be the foot, the ankle, the hip, or the chest, or anything. In somebody who's younger, it's usually easier because the competition isn't as great as Dr. Sheppard said on that slide. so the stakes aren't as high, the intensity is not as great, the amount of trauma is not as high. So little league, t-ball and scrum soccer, as we used to call it, where it's just a big mass running around. That's not the same as what happens in middle school and then high school. So really, you have the opportunity to like, again, using Morgan's example, let's play golf or tennis or recreational swimming, as opposed to doing the most intense competitive sports at the highest level. It just gets harder in high school to take things away as opposed to build toward that. Musical instruments, that was a question about that. I think it's a great thing. And I mean, my brother, of course, he had to play the tuba and, carry that in the marching band, but he didn't know. So, you don't, not everybody has to play the flute. I mean, I think all the musical instruments are going to be fine, basically, as long as you're doing them, reasonably. I mean, you can play the drums like somebody in Aerosmith and really have intense stuff going on, or you can play the drums like most people play the drums. So again, everything has its own levels. I think that's what the main message that we want to take away here. Choose the activities in a really reasonable way and be practical and have fun and live your life. And we don't like to put restrictions on things that make sense. We just want to understand, what drives people to want to, maybe have behavior that might not be as safe. And then let's try to understand that and try to put it back in maybe a different realm, with the recognition that we really don't know what a lot of things aren't safe. We kind of err. We always err on the side of your safety. That's just the nature of our business, your well-being.
Thank you for that. Mary, I just want to, I don't want to ask you the same question because Alan kind of answered that, but maybe you can address more something that somebody's asking in the Q&A box about how do you advise families what to do with their children in PE at school or fun runs, and what do you tell families about that?
Yeah, I think that is a really important question, and it's real. A lot of patients will come and ask, Dr. Sheppard, can you write a letter to excuse my child from PE requirements? And what I often say is, I don't want your child to lose out on the opportunity of PE class. Right. Maybe you can't do the timed mile, but I don't want the alternative to be that you're sitting in a different room by yourself, having 45 minutes to do homework. I still want you to be active for 45 minutes. What is it that you can do that's not as intense, but that you're still getting all of those great benefits, which is why we want all of our students to have the exposure to PE, that type of thing.
Great. Morgan, can you just build on that? What does your son do in PE class? And do you feel like he's getting enough exercise outside of school? And maybe talk about that a little bit.
Yeah, I mean, I was same as Dr. Sheppard. Like, I didn't want to take him completely out of PE. I wanted him to participate, not only for the fact of let's get the 45 minutes in, which, yeah, I could do that at home after school, but I also wanted him to feel like a normal kid. I think that's the biggest thing, that the kids start to feel that I'm not like everybody else. I can't do this. And at least if you're in the room and you're participating in parts of it, it's, the feeling of normality is there. He doesn't participate in the isometric exercises. So every day in gym, they do push-ups, burpees, sit-ups, those ones he's not a part of. He does jumping jacks while they do it, but he does run the mile, not as fast. He's, one of the slower ones, but he jogs the mile. They play a slew of sports. And when it's the rugby day, they actually put him at the very back. And so he still looks like he's participating to everybody else. Does he actually get involved in it? Not really, but that's one day every 3 weeks. So it's just about being there and being a part of it too, that is really important, especially with young kids. Nobody wants to feel like the person that's not included, or and it's noticed. Kids notice that you're not in gym class. And outside of school, I mean, I wouldn't say golf is like very intense. He's not exactly exerting a lot of energy doing that, but we have found to like ride our bikes around the neighborhood, and we find new paths to go on. It's actually like become more bonding. He likes to shoot a basketball. I mean, you know, like I said, leisurely. He's found a lot of friends that like to shoot basketballs too. And they may not play on the basketball team for other reasons. It might be that they have asthma, or they just don't want to. They have another thing that really interests them, like the tuba. And so they commit their time to that. But, you know, there's kids along the street that none of them are on the basketball team, but they all shoot baskets in the cul-de-sac, that he can at least be a part of that. And I'd say the majority of people forget that he has a connective tissue disorder, because we try to involve him in any way that he can be within a safe realm, knowing that he knows his restrictions too. I think that's my big thing with him, especially young age and growing up with it, is he needs to advocate for himself. I'm not in gym class. I never will be. If he can't tell the teacher, I can't do this, then we already have a problem. So I'm really big on him knowing his limitations already and not telling him no. He needs to, you know, make safe decisions on his own, which is a lot to ask of a 12-year-old, but you know, you have to start somewhere.
Exactly. That's really a great point. Samantha, people want to know about your swim workouts, and how did that change when you were diagnosed?
So I wasn't diagnosed until after I kind of stopped swimming. I mean, I still swim leisurely, but I wasn't diagnosed until I was 24. I stopped swimming for a team once I left high school. I didn't swim in college, but in high school, we kind of had an idea that I had something, but obviously there was never a full diagnosis. I was always in the slower lane. I would take the extra time. And when we had our sets, I think we would go on, depending on what it was, sometimes we would go on like 30-second intervals or a minute intervals. And I would take the extra time to catch my breath and then be like, okay, I'll take 5 extra seconds than what they usually do, and then go, just so I could catch my breath and go. And then I also did not dive into the pool, which my head coach in high school and during my neighborhood swimming during the summer, they were very accommodating to it, and the officials were too. With everything, I kind of like, as I got older, I saw my friends getting faster and I wanted to get faster as well. So it's just kind of like, it's almost like a peer pressure thing. But I did what I could, but I didn't exert myself to the point where I couldn't breathe when I got out of the pool. If I saw that I was getting to that point, I would completely stop and catch my breath and then go again. I never let myself go above the limit that I knew that I couldn't do.
Yeah, that's good. I want to talk a little bit about knowing your body, but first I just want to thank Dr. Braverman, because he has got to sign off for another commitment. So we're gonna keep going here. We have Dr. Sheppard here with our panelists, but I want to thank Dr. Braverman tonight, and we'll be sharing the slide presentation with you all as well as the recording, and you'll be able to ask further questions of him afterwards. So we'll move on, but thank you, Alan.
Thank you, everyone. I'll leave my email on the chat, and I'll do my best to answer your questions if I can. Even the ones that are more specific to you, I'll do my best. The one question, somebody did ask just about intimacy. So before I end, I will say that we do address this in our writings. Sex is also very important for your health and well-being, and the level of physical activity associated with routine sex is no more than mild or moderate aerobic exercise. So as I tell everybody, it's just like any athletic activity. You can have any level that you can think about, but when you do this in a recreational way that's safe and low risk, it's safe and healthy, and we certainly wouldn't want to dissuade anyone from intimacy.
Great, thank you for that.
Thanks. So I'll put my thing on there, and then I'll exit out. Thank you so much.
Okay.
Sorry I have to leave, but I have another thing that starts in about 1 minute. So.
Okay, so I'm going to go over to Alan Tucker now. I mean, Samantha was talking a little bit about knowing her body. Somebody is asking Alan, what were you told you can and cannot do when you were diagnosed? And how do you, like, moving forward, like, how do you evaluate your body and what you're doing and what's right for you and what's not right for you?
All right. Yeah. So the black and white thing I was told I can and can't do was free weights. So dumbbells, the big barbell that you see on like the racks. Basically any kind of like exertion where I am like sets to failure. So you're trying to do the maximum amount of weight until you literally can't even push it up anymore. So none of that. So I forgot the scientific word for it, but I was told it, but I understood what he was saying. And so what I've replaced that with is resistance bands. So I know that's not, I mean, it's pretty accessible nowadays, but those movements I would do with the barbell or with dumbbells, I just do it with resistance band now. And so now it's all body weight stuff. I don't, as hard as it is, I don't touch a free weight as much as I want to, but it's just taking out that, lifting till you collapse kind of thing, which is a great feeling. Before I, was diagnosed, I love that feeling of you feel like you did everything you possibly could in a run or in a lift. But I realized it was also very detrimental to my aortic root. So we got that figured out very quickly. And so that's pretty much that's the only thing they told me to cut out was the heavy lifting, and then do more body weight stuff. So even like low intensity push-ups, and things like that. Yeah.
That's really insightful. Oops, I just lost your pictures. Okay, Mary, I wanted to ask you, because Alan's talking about all this weight work. A lot of people are worried about or concerned about building muscle mass, and they want to know about weights and muscle mass. And is there anything about these connective tissue conditions that prevents people from building mass? And then how do they do it? I mean, I think Alan talked about it a little bit, but can you address both the possibility of it and what you recommend?
Sure. Yeah, I think that it's really interesting. We've seen, at least in mouse models of Marfan syndrome, that there are physical changes to the muscle structure. Now, can a person with Marfan syndrome build muscle mass? We don't have a lot of data right now at the University of Kentucky. We have a study where we're looking actually at hip function and the relationship to range of motion, strength, the hip joint. And it's an area of need so that we can understand. But in general, my clinical observations are that people who have heritable thoracic aortic conditions, whether it be Marfan syndrome or other connective tissue disorders, they can still build muscle tone within a spectrum that is improved for them. Maybe they won't bulk up like what we see on, when I was a kid, Monday Night Raw for wrestling. But a person, even within the range of maybe having a less exaggerated bulk, can still have more tone, and that can have a tremendous impact on stabilization of joints, just like what Morgan was talking about with their son.
Great, that's really helpful. Let's look through the questions here to see what else you want to ask you all. I know everybody is most concerned about, especially with Marfan and Loeys-Dietz, the biggest concern is with aortic dissection. Do either one of you think about some of the other issues as well, like the joint issues, eye concerns that have been talked about tonight? Alan, do you want to take that?
Yeah. One more time.
So obviously the heart and aortic issues are the biggest concerns, but they also talked about, we have in our physical activity guidelines, which Helene shared the link for, there are other concerns like do you have joint issues, tendon issues, people with connective tissue conditions, especially Marfan, issues with their eyes. And do you have any of that? Do you worry about any of those kind of things?
Yeah, very minimal. My ankles crack a lot when I run towards the beginning. My shoulders they'll pop when I start throwing a football or start to do some tricep pulls or things like that. But I hope I'm like everybody with Marfan syndrome. After a while, you get used to it, and then it kind of smooths out, like you're almost putting oil on your body every time you work out. So a lot of cardio, and I think it kind of just gets your body more loose. I do a ton of yoga, and I think that helps with the joint pain. I'm always doing something called hot yoga. It's like a sauna basically, but you're stretching in it, and I don't do the full workouts in it, but it's helped me tremendously with just that joint pain, the joint cracking, the aortic root though, like being worried if it's going to increase or decrease. You can leave all your worries behind if you stop doing the high intensity workouts. That's what I was told by my doctor. And then when I was 18, from 18 to 24, there was a significant tail off between how fast my aortic root was growing and how it basically slowed down. It still grew a little, but when I stopped doing all that high intensity weightlifting, with free weights, and I was literally running my body into people, which probably isn't good. But as soon as I stopped that, I was able to withstand for another 6 years before I even had to talk about surgery. So, there's definite improvements when you change up how you work out. But yeah.
Then I think it's important to note that even after the surgery that you had, the rest of the aorta is kind of at risk, so you still need to maintain those, the limitations that you put on yourself and still be smart about it, right?
For sure. And you know your body better than anybody. So every now and then you feel free to push it a little bit, just because it's nice to know I can go another quarter of a mile, or I can do a couple more reps. And so it also helps you out. I feel like I've gained strength since I was diagnosed, and I've gained muscle mass since I, had the surgery even. So I may be a unique, patient, but I think I'm also not stretching the boundaries, but I'm definitely, testing myself at times, not in a bad way, but I'm finding out more and more that the more confidence I get, the more I can do. And then I haven't seen any negative changes to my body since I've started doing that. So
that's great.
Work smarter, not harder.
For sure. Yeah.
Samantha, how about you? How do you feel about that? Do you have other issues that you're worried about with the joints and all that kind of stuff?
It's funny. My mom's actually commenting a lot in the chat, but I did have a subtalar fusion when I was born 6 weeks premature, and a doctor kind of prematurely diagnosed me with a club foot when I never really had it, and so I had a lot of the club foot corrections and recorrected my whole foot. Anyway, I was never really supposed to run just because I can't with my foot. And that's why swimming was always good for me. But with my foot and everything, running was never really an option. I was one of those that, when you had a PE note, that was me. I was one of the first ones, not only at my college, but in my high school, to have a physical 504. Which, for those that don't know what a physical 504 is, it's basically like a 504, but with physical limitations on it. And so that was the main thing for me, is like swimming was the best thing for me. The one thing that I always did worry about was, I think it was this was more in high school, of a peer pressure of like, people always would come up to me it was after sophomore year of high school, saying like, it's not fair that you don't dive in the pool. When I would be like, it's actually not fair that you get to dive in the pool, because diving in the pool gives you a 5-second head start. But it's just one of those things I always like. It was more in high school that I struggled a lot with in swimming, because Mary, I'm sure, I'm from Kentucky as well. I swam for the #1 high school in the state of Kentucky, and we're probably top 25 in the country. So having that kind of, I don't want to say pressure, but seeing all those, we have had a couple Olympians come through, kind of knowing that pressure of, I swim for a really good high school, I need to be up there as well.
Yeah, that's thank you for that. And thank you. I want to thank your mom also for chiming in the chat box. It's great to see her involved in there. I know we've gone over a bit. I wish we could sit and talk to everybody a lot longer. I also just want to say that you guys have asked a lot of specific questions in the Q&A, and also that you pre-submitted. And we Yeah, we don't normally do this, but I normally would just say, if your question wasn't answered, put it in the, submit it to us through our website. But I really want to take all these questions. I know Dr. Sheppard's already answered a lot of them for me separately. I'm going to try to put something together and send it to everybody who registered so you can see all the questions and all the answers. We'll do the best that we can with that, because I think it's really important. And I know you all want the doctor to tell you what you can and can't do. And I think we tried to give you guidance today so you can make your decisions. And with Morgan and Samantha and Alan, we tried to give you some insights into how they've changed things and some of their attitudes about it. So I think that's a big part of it as well. And so hopefully that you are all empowered to do what's best for you and your family, and only you really with your doctor can decide that. So I mean, even your doctor will just give you guidance and you still have to decide for yourself. So I'm going to thank all the panelists tonight. I really think this was great. Glad we finally got to do this. And what I'm going to just do is do a little wrap right now and just tell everybody else what's coming up for the Marfan Foundation, since this is kind of like the beginning of our year. We're in the fall. So let me go back to my sharing my screen here. Okay. So again, here are the URLs where you could submit your questions if you have additional questions that you think of afterwards tonight. And that's Jen Lynch, the nurse who is the head of our Help and Resource Center, and she'll be glad to answer any additional questions that you have. We have some more webinars coming up. We have a question and answer on life insurance from somebody in the industry who's done some research on this for people with Marfan and Loeys-Dietz and VEDS. And I know Morgan's already given us a lot of input into how to direct that conversation. So we're really excited about that. And then in December, we have a session on Marfan, Loeys-Dietz in children, more than medicine, where we have some specialists from Stanford Healthcare who are going to weigh in. And it's not just about the physical health, but some mental health issues as well. So that's gonna be really great. We have our virtual support groups. We have teen and kids meetups online. And I think Helene's going to be putting some of that information in the chat box for you. I'll send links as well in the follow-up email. As we mentioned earlier, if you were here for our little chat before we started, Walk for Victory is coming back, and we are so far scheduled to be in person in Cleveland, St. Louis, and Orlando for the rest of 2021. And then we have probably about almost 20 other walks coming up after that in the spring, or starting in February, really. You can look at all the walks at marfan.org/walk, and see we will have COVID protocols in place where they're necessary, when they're necessary, whether it's mask, social distancing. We'll make sure it's safe for everybody. And if we can't do it in person, we'll let you know. But we are going to have a great year with Walk for Victory this year. The VEDS Birthday Bash is coming up October 7th. VEDS movement is well, they're celebrating their 2-year anniversary with us, their 2-year birthday. And that's gonna be a great online event, October 7th. Morgan's there giving it the thumbs up. And also, I just want you all to know we're here for you. And so if you have any other recommendations for other webinars, email them to me, reply to the one of the emails I send out and tell me what you're interested in. If you have questions, we're always here for you. Tell us what you need. And we're here to make your life better as much as we can related to these conditions. So thank you again to my panelists. You all were amazing. And thank you all for coming tonight. Look forward to seeing you at the next webinar. Take care. Bye, everybody.
Thank you.
Thank you, Helene.
Thank you.
Thanks, everybody. Have a good night.
Night.